Hi, I'm Phil Goodwin, a Senior Business Development Manager at Docobo. In 2008, I joined the team, and over the past 15 years, I've worked closely with various clinical teams around the country to develop different clinical pathways and embrace remote monitoring to support the proactive monitoring and reactive monitoring of patients. In 2022, I started working with the team in Northamptonshire.
My name is Pedro. I'm the team manager for the assistive technology team. I'm also the project lead for the implementation of remote monitoring in Northamptonshire. Looking at different ways and different models to try and find out what would work best for us. So part of that strategy, we contacted and spoke with people from health, or colleagues from health, as housing and fire services, etc. So what we're trying to do is to find as much information and compile a strategy that worked for all of us in Northamptonshire. What we did was create a masterclass where we invited local authorities and other health professionals from across the county to talk to us and explain what they were doing. What I wanted to find out from them most specifically was if they could start again, what would they do? And what they gave us was a lot of information about what you needed to start, but specifically what you needed to avoid. The other thing they gave us was the ability and a choice of different providers available. And through that, and through an options appraisal, that's why we decided to go with Docobo, because it was the one who met the criteria of all the things we wanted to do, such as the video calling facility, the ability and the flexibility of changing all the question sets and create a software system that works for us. So that was really useful.
Hi, I'm Paula Love. I'm lead nurse for Integrated Care Northamptonshire, and my job role is around clinical pathways, particularly focusing on frail and older people. We started looking at remote monitoring as a means of proactively identifying when people were deteriorating, rather than as we're used to doing in a proactive type way. Coming out of COVID, reached out to a workforce that was already not predominantly patient facing. So approached senior nurses working through the bank to see if we could pull together a clinical hub, which now operates from 7:30 in the morning till 11:30, 7 days a week, working really closely in partnership with social care to enhance our model. And the other advantage of working with the assistive technology team is equally, if the patient hasn't got a lifeline, at the same point of installing the Docobo equipment, they will also install a lifeline. So we're really trying to wrap services around these individuals to help them live well, stay well, and age well by wrapping it all around.
And that model that we were initially based on, we refer to as the Barcelona model, which is around providing support to people in a more proactive way, collecting data, finding out things that are working or not working for the person, and putting a response, community response services in place. So that has been our aim to begin with, and obviously things have expanded and scaled, obviously, to the point where we are now.
Following early discussions with Paula and Pedro at NHFT and the local authority in Northamptonshire, we identified 3 key work streams to address. The first one would be the care home model. This comprises of 3 key question sets initially. Number 1 would be the monthly wellness check. This acts as a general well-being for each of the residents in a place of care. Number 2 would be the MDT. This would support the GPs and the AMPs with the weekly ward round requests. And number 3, the most reactive question set, would be the one called Is My Resident Unwell? This question set is used to identify those residents that need a same-day appointment and has an SLA typically of 2 hours. The second key area we would look to address would be long-term conditions in community, and the areas that we would start with would be cardiac, respiratory, frailty and diabetes. The third area that we would look to address would be the virtual wards, and this would comprise of 2 key pathways. Number 1, admission avoidance. This is where patients already monitored on Docobo would look at a point of deterioration in their health to have an increased monitoring package, typically 3 times per day, and this would attempt to avoid that admission into care in an acute setting. The second element would be those that have already been admitted into an acute setting would be identified for an early supported discharge. This would allow them to go back to their place of care, be that in a care home, nursing home or their own home, where they would continue to be monitored at a frequency agreed with the virtual hub.
Specifically, the partnership with health is extremely important, and I don't think we would be where we are without having their involvement. Obviously, they bring a lot of knowledge, they provide the clinical support, and obviously what allows us to do is to create a service that is responsive and can support, and I think it's quite important to say that this service is not there to replace existing services, but more to complement everything that exists already, and that's been our aim since the beginning.
We want to use the system as a sort of multi-layered approach. So there are those patients that are much more self-managing, and we only respond to them when absolutely needed, if they alert on the system. Otherwise, they are left to manage in their own way. And there equally are those patients that maybe alert on a soft sign because they need a bit more reassurance and guidance. So they're not necessarily alerting on anything clinical, but they need that reassurance and support. And that's okay, that's part of the hub's role as well. By that integration with social care, the call care team, we're able to provide that soft support as well as the clinical support, identifying those people that would benefit from both medical and social.
The model in Northamptonshire is truly innovative. The joint working between the local authority and the NHS clinicians has allowed us to create what we call the virtual care team. This virtual care team has a variety of skill sets within it. We go from the healthcare assistants that support the onboarding of the patients, the general clinicians that support the GP practices and the AMPs with the care homes and the residential sites. And we also have a variety of specialist clinicians that support things like the monitoring of the ECGs for the cardiac patients. As well as that, these particular roles are made into substantive positions and bank positions. The bank positions allows us to be dynamic in our resource, so therefore for the peaks and troughs, the increased referral rate at certain points allow us to dip into that extra resource for those periods. And finally, we have a combination of the virtual and the physical presence. So where we have installations in the community or the go lives in a particular care home or PCN, we still support that with the assistive technology team and the virtual care team to make sure that they feel there is that wraparound.
The benefits that we've had have been that we've been able to pick up things like high blood pressures that have not been treated and able to get that treatment started. By the same token, we've been able to get a lot of de-prescribing done for treatment that's no longer necessary because we've got the evidence that actually, perhaps that blood pressure is low now, doesn't need that same level of intervention that it needed before. So it's really proactively been able to support those patients. And the other thing that we've been able to do through the clinical hub is notice those early signs of deterioration. So picking up infections early, acting on them. And that's happening about 3 to 5 days in advance of that infection really taking hold. And we work very integrated with our rapid response service. So where we need a face-to-face assessment, we integrate with the rapid response. So the remote monitoring is really about complementing the existing services that are already there and almost providing that helicopter view of what's going on with that particular person at any point in time.
There's been quite a lot of benefits already. So one of the things that we can produce obviously is reports based on interventions, number of interventions, and exactly what outcomes have achieved. So we see a significant number of interventions, and they have increased massively throughout the months as we went live. We have added additional customers and patients in residential homes. So those outcomes are seen and easy to evidence.
Obviously, we have measurements, we have KPIs, and the way that we are measured currently is around the clinical team's response to our red alerts. So we have 30 minutes for a red alert response, and we have 2 hours for an amber alert response. and that enables us to measure if we're being effective. Also, for those red responses, make sure that we're de-escalating as quickly as possible to reduce the risk of that person being admitted to hospital. And also enables them to clinically identify by red and amber the priorities. The other measurements are for each of our residential homes, reducing the amount of same-day duty doctor calls by the hub intervening, and reducing ambulance calls and ambulance see and treat. So not necessarily reducing unplanned admissions, but definitely calls to ambulance and see and treat ambulances. So looking at those individual settings to see what their baseline is and whether we're having an impact. If the clinical hub is intervening frequently through the ward rounds, through the is my resident unwell data that we ask them to submit, then we can make an impact on reducing those. If the hub feels an ambulance isn't required, then we can call rapid response and get them to support the care homes or somebody in their own home. But those are the measurements that we have in place to see whether the hub is being effective or not.
So how have we evolved? We've identified the key care packages and put them into pathways. We call this multi-level monitoring. An example, a COPD patient deemed stable may be monitored once per day for their LTC. Post-exacerbation, they may need to be monitored 3 times per day by the virtual care team, but they also may need to be made known to another clinical team. In order to do this, Docobo would require a continuous level of interoperability. Docobo successfully integrated with a variety of other care and health platforms and EPRs. This allows the respective clinicians to have access to the appropriate patients at the appropriate times.
Giles West, and I am Deputy Director of Operational Transformation for Northamptonshire Healthcare, which is a community trust provider. But I'm also our system for Northamptonshire ICB, our Ageing Well lead, and have been working across multiple organisations for many years, trying to bring different ways of working and improve outcomes for our older people. We're in year 2, about to head into year 3 now of our transformation journey in Northamptonshire. So this is a very exciting time for us. We see those shoots of change beginning to grow and be nurtured and developed. Our ambition in 5 years' time is that we would have 10,000 people living in their own homes with remote monitoring, being supported through our hubs, wrapped around with the support of our integrated neighbourhood teams, and that we would have covered all 5,000 people in older people who are living in 24-hour supported care settings. We know that if we can reach that level of scale and spread, we will have the impact, continue to have the impact on unwarranted demand in terms of urgent care and primary care appointments, and make better use of our clinical time, but primarily support more of our older people to live the best lives that they can for as long as possible.
I don't have to worry. 2 hours and there'll be somebody on the phone or here, and that's a big comfort,
Feel safe when I'm being monitored.
It's definitely cut down the visits to the GP. I would absolutely recommend it 101%.
If you have a chance to go on this, yes, grab it. Grab it by all means, because it's a lifeline. It is a lifeline. I mean, they're out there, they can ring you up, you get contact with somebody, you can tell them about your troubles or anything you're feeling. They're there, they'll answer you, and they'll get in touch with your doctor for you straight away within the same day, 2 hours.
Duke's Court has really improved since using the Docobo service for ambulance call-outs within the home. So it's really reassuring that we've got that team of nurses that we can go to for advice if we're concerned about a resident, and they're very prompt, very swift. I think it's about a 2-hour call time, but we do find they're calling back very quickly, usually within half an hour.
And it's just that comfort factor, it's just that absolute reassurance that you've got somebody there knowledgeable and reassuring to be able to tell you everything, you're doing okay.